I'm Derek Hall. We'll be performing a live ultrasound evaluation of the lateral knee. This video is not meant to be a comprehensive review of this topic. Rather, our objective is to cover the core competencies as outlined in the AMSSM Recommended Sports Ultrasound Curriculum for Sports Medicine Fellowships. We'll now perform an evaluation of the lateral knee. For the lateral knee evaluation, I like to start actually at the patellar tendon anteriorly, and then we can move posterior from that. Once that tendon goes away, the first hyperechoic fibrillar structure that we're going to encounter is going to be the iliotibial band. So that's a good way to keep yourself straight as you're looking at the lateral structures of the knee, which can sometimes get confusing. So as we come back, we'll see the iliotibial band at this location here. Here's its insertion onto the tibia. So this would be Gerdy's tubercle. We can then follow that up proximally as it crosses over the lateral knee joint and up over the lateral femoral condyle in the long axis here. You have to pay attention to the amount of flexion that your patient has. I usually like to have them just in a little bit of flexion and kind of move them between flexion and extension as I'm doing this evaluation. So once we come up to the lateral femoral condyle, at this point I'll turn into a transverse scan to get a short axis view of that iliotibial band over the lateral femoral condyle. And so we want to have the condyle nice and flat and horizontal as you see here, which will allow us to see the iliotibial band, which is a structure that sits between here. So we want to look and follow it all the way posterior as it comes around here, and then it's going to move all the way anterior, and we can see it'll even have some connections all the way over to the patellar retinaculum and the patella, which sits here. So this view is important because we can evaluate for any focal thickening of the iliotibial band, which often happens more towards the posterior aspect. There may be some focal hypoechogenicity in that area as well. And then we want to look for any fluid collections. And there's two potential spaces for fluid collections at this location. One is simply fluid from the lateral recess of the knee joint. So that fluid would come from here and would come along and lie close to the femur in this location here. The other potential space is in the iliotibial band bursa itself, which is going to lie just one layer up, and it'll sit just below the ITB. And so with a little angulation of our transducer, you can appreciate right at this level here, right at the arrow tip, is another small potential space, and that would be the region of the iliotibial band bursa. So if a patient has true bursitis at this location, you may see a fluid collection there. Again, always use light transducer pressure so as not to displace small amounts of fluid. You can perform dynamic evaluations here as well if there's associated complaints of snapping at the knee. So we'll move back into our long axis view of that ITB as we scan down, again towards Gerdy's tubercle. Now as we move back up, we're going to come across the lateral joint line. So here's going to lie our lateral meniscus. And so we want to evaluate that similar to the medial meniscus, looking for any hypoechoic clefts, any associated perimeniscal cysts, or other signs of meniscal tear. You can evaluate this in the anterior aspect and then continue to move posteriorly, angling your transducer in to get your best evaluation. So if we move slightly proximal along the femur, we'll see this characteristic notch within the lateral femur, and that's going to be where our popliteus lives. And so here's going to be a relatively short axis view of that tendon, and then we can turn into a long axis view. And remember, this tendon is going to originate from the deep popliteal fossa, and it's going to come up to insert at that location. So it makes a rather tight turn right around that location. Therefore, there's a lot of anisotropy when trying to visualize this tendon well. But here we can see a fairly good view of the tendon at its insertion site, and then as we try to follow it around the turn here, imaging will get a little bit more challenging, and then we'll follow it back. Usually at this point I would save the rest of the evaluation to happen with the posterior knee eval, where I think it's visualized and appreciated a bit better. But you can follow it all the way around and all the way around as it comes around there and then inserts up in that characteristic notch. Now at this level, when we have the long axis view of the popliteus, just sitting above that is going to be the fibular collateral ligament. So we can see this slightly different tissue right through here. So that's going to be our FCL. And then we want to just angle our transducer down towards the fibular head to bring that FCL into view. Oftentimes this can be a bit challenging in this position because there's a little bit of valgus at the knee which can make this ligament lax. So you can try to put the patient into varus. Here we do have some pillows built up, but it still does have a little bit of laxity in this ligament, which is just due to positioning. So FCL is here. We can see it as this structure running here. We can see it dip down a little right at this location, and then it comes down, and here's its insertion onto the fibula. This is the tibia below, so we actually see a small amount of fluid within the tib-fib joint right through here. And we also see a fair amount of anisotropy occurring all along the FCL. And this can complicate imaging a bit. If we angle back and forth, we can use that relative anisotropy to identify the fibular collateral ligament here, which is now more anisotropic. And this other tissue that we're mentioning is the biceps femoris tendon. And so we'll come back to that in just a second, but here again we can see the FCL insertion, and we can follow it along. We can see it is a little bit lax. We can follow all the way up to the femur here. Now as we're back at the fibula, we're seeing this tissue here, this stuff coming down around here. So this is all the biceps femoris. And so what we want to do is anchor the distal end of our transducer at the fibula and then rotate the proximal end slightly posterior until we get the biceps femoris in view. So now we're seeing our biceps femoris tendon here. We can follow it up here, and then we come further proximal, and we'll begin to see the biceps femoris muscle tendon junction at this point. So if we follow this back down from the muscle tendon junction and get over the long axis view of the tendon here, we'll actually be able to appreciate that there are some fibers that are going to go down right here, insert onto the tibia. And this is not uncommonly seen, and so this can again lead to some difficulty in calling tendon pathology, because you'll have a lot of anisotropy here. We'll try to show that again as we see some of these fibers acutely turning here that are very anisotropic due to the acute angle, and they're going to come down and actually attach onto the tibia, and then we have the remainder of the fibers coming back here going onto the fibula. So if we turn into a short axis view here now, sometimes this can be helpful. So we'll come back. We've got anterior on the right of the screen and posterior on the left. And so here's going to be that distal biceps muscle, and here will be our biceps tendon here. And so as we follow this down, we're going to see the fibular collateral ligament, which sits right here. We're going to see it come in, and it's going to become a little bit anisotropic, and it'll move down here, and now we see the biceps coming in, and we'll see these two kind of come together right as we go down towards that fibular insertion site. So we can follow that back up, and again there's the biceps. That FCL is going to kind of move its way right here around those two limbs of the biceps as it comes down. So just don't confuse that with pathology, either of those two structures. Now at this same plane, if we continue to move further posterior, we'll see another structure that looks somewhat similar in short axis, and that's going to be the common fibular nerve. And it's going to lie right back here. And so at the level of the biceps muscle, once we come down and that starts to go away and the tendon starts to form, the common fibular nerve is going to lie right back here. And this is a fairly reliable place to pick this up as it comes out from the sciatic nerve and leaves the tibial nerve. And we'll follow that again with the posterior evaluation. But when looking from the lateral aspect, this is an easy way to go ahead and pick that nerve up. We can then follow that down in its short axis towards the fibula, and we'll see right here is that common fibular nerve. Here's our fibular head, and then we'll see it move right here around that fibular head and go into the fibular tunnel right here as it's going to dive down between the two heads of the fibularis longus. And there's that nerve again. And that will complete our lateral evaluation.